everybody.
Yes, we can hear you. You can go ahead.
Do you see my presentation?
No, we cannot see your slides at the moment. You can take a couple of minutes. That's fine.
Je pense que c'est bon, là, qui est prêt. Do you see my presentation or not? I will share my screen with you.
Do you want to try sharing your screen and then we can let you know if we can still see your presentation or not?
Okay. I share the screen with you. Second chat. Partager, ok.
Yes, we can see your presentation. Lovely.
You see the presentation. Okay.
Yes, we can. You can start.
Okay. So, first of all, I would like to thank the organization committee for the invitation to speak about this subject, which is repeated implantation failure, a stressing situation that needs a calm management. You know, a successful implantation needs a good quality embryo, a receptive endometrium, and a synchronization between endometrium and embryo. So when we make an embryo transfer in IVF and there is no pregnancy after one embryo transfer, it can be a bad chance, can be just a bad chance because it's known that there is something called embryo expulsion after embryo transfer. So if in one embryo failure, implantation failure can't be just a chance because of embryo expulsion. But if there is no pregnancy after many embryo transfer, here is a repeated implantation failure. And there is a repeated implantation failure, the bad chance or the chance seems to be less probable. Okay, and here it's more probable there is a problem. Okay. So it's a stressing situation, both for patients and doctor. And it's, as I said, not question of chance at that time. So what's the definition first of a repeated implantation failure in IVF? So when we look into literature, we see that there is no consensus in the literature on the definition of repeated implantation failure. So there is many definitions. What's common between the more recent definitions is the good quality embryo. So these definitions exonerate the embryo as a cause of the repeated implantation failure. So a repeated implantation failure in this new definition is a repeated implantation failure of an euploid embryo, of euploid embryos. So we have to look for other cause than the embryo. Why diagnosing a repeated implantation failure is important? So the diagnosis is important to detect patients with such problem, to propose them adapted exams and adapted treatments. So what's the frequency of the problem? This question was discussed in Journal Club of the American Society of Reproductive Medicine, and the group discussed the results of the study published by Paul Pirty and all, entitled Rate of True Recurrent Implantation Failure is Low. Results of 3 successive frozen euploid single embryo transfers. It's a very interesting study in which 4,429 patients had 3 consecutive transfer of one osteoblastocyst. And the cumulative sustained implantation rate after 3 consecutive frozen upload single embryo transfer was 95%. And the cumulative live birth rate after the 3 consecutive frozen embryo transfer was 92%. And the conclusion of the authors was that true recurrent implantation failure is rare. For those patients with the ability to make haploid blastocyst, less than 5% would fail to achieve a clinical pregnancy with 3 embryos transferred. More recently, Pavangil, Barisata, and Garcia Velasco published in Fertility and Sterility a study entitled Does Recurrent Implantation Failure Exist? Prevalence and Outcomes of 5 consecutive haploid blastocyst transfers in 123,000 patients. And the conclusion here was that recurrent implantation failure is an incredibly rare occurrence, less than 1% after 5 consecutive haploid embryo transfers in patients with otherwise good prognosis. So what's the risk with excessive diagnosis of repeated implantation failure? The risk is to make useful interventions with psychological impact, with cost, risk of complication, and risk of having less chances in next IVF. So we have to be careful before any intervention. And we have to wait until there is enough arguments to think that aneuploidy seems not to be the cause of the implantation failure. And so when do we have to start exploring for a cause of implantation failure? Ideally, we have to start before the first attempt of IVF. So before starting the first IVF and before doing the first embryo transfer, we have to check for all the causes or routine causes of implantation failure, such as lifestyle factors, smoking, alcohol, uterine factors, adnectal pathology, and these causes are very known, like hydrosalpinxis, like polyps, like myomas, and it's also important to have a good technique of embryo transfer, which also involved in implantation failure. And now, if we have checked for all these causes, and then we have made many transfers of good embryos, and there is no implantation. So what to do? Here, there is many exams which are proposed in literature, such as hysteroscopy, screening for thrombophilia, the PGTA, pre-implantatory genetic test for aneuploidy, the DNA fragmentation, and the endometrial receptivity array test. We will start one by one to see which one is important and which ones are less important in this case. So for the hysteroscopy, if it's not already done, it's important to do a hysteroscopy in case of repeated implantation failure with a special care for chronic endometritis, which was proven in many studies that severe chronic endometritis causes implantation failure. We have to screen also for thrombophilia, which is the estimated frequency in case of repeated implantation failure. Now varies between 4 and 62% in the different papers published. And the treatment in this case will be with low molecular weight heparin. Pre-implantation genetic testing, the PGTA, also have a place in that case to verify that the embryos we are transferring are haploid and it's not a problem of aneuploidy. And we check also for the karyotype, for the parental karyotype, as in many published studies, there was a higher parental chromosomal abnormality rate in the group repeated implantation failure. And the most encountered anomaly was Robertsonian translocation. For the sperm DNA fragmentation, here there is not really established scientific scientific lien. It's shows the association. There is not association with established with repeated implantation failure, even if in miscarriages there is an association with which is established. What about the test ERA? ERA is on the material receptivity array test. So theoretically, this is a test which is very interesting, which permits to have a personalized detection of the implantation window. So for the patients who have many failed implantation, the idea is probably the window of implantation of this patient is different from the most of the patients. So what you do is the technique is simple. We prepare for an embryo transfer, and then instead of transferring the embryo, we make an endometrial biopsy, and then we analyze the endometrium with the NGS technique to see if this endometrium was in the implantation window or not. And then we have the result of the test. This is the result of one of my patients. So we see with the arrow, you see here, the test says that the biopsy was done in pre-receptive embryo. You see here, we must be here in the receptive window. Sometimes we are in the pre-receptive, and some patient will be in post-receptive. And the interpretation of results are like that. Donc, according to our internal data, 89% of women with similar endometrial profile reached receptivity following the given recommendation. The recommendation was to make the embryo transfer 1 day later than the time at which this endometrial biopsy was performed. And for this patient, I did the transfer as it was recommended, and the patient was not pregnant. And for the ERA test, there is a problem. There's a problem, which is when we do the recommendation and our patient is not pregnant, we don't know if we have the next time to transfer the embryo with a classic transfer or to repeat again this recommendation which doesn't give results. So this is the problem with this ERA test. This ERA test, I use it and our team used it for some patients, and we were not really satisfied with the results of the ERA test. For this patient, for example, she was explored later, and we found a chronic endometritis that was treated, and we made a classic transfer without this recommendation, and the patient was pregnant and she had a baby. Oh. Many studies and reviews concluded later that the ERA test is not really actually a proven technology, and we have to wait to have more evidence with this test. So what are the treatments in case of repeated implantation failure? So many treatments are available in the literature, such as endometrial scratching, immunotherapy, and other treatments. So for the endometrial scratching, the literature doesn't conclude yet. So it seems that endometrial scratching gives the increases implantation rate in the group of patients of 3 implantation failure or more. But in the group 1 implantation failure or 2 implantation failures, it seems that this action is not useful. Other tests, other treatments like immunotherapy, antiralipid, glucocorticoids, the GM-CSF, so should be limited to research setting only. And here I present my personal 2 years data of 2023 and 2024. So in these 2 last years, I saw 24 patients with a history of 3 or more implantations failure. And the exploration detected in 22 of these patients mycoplasma in endocervical sampling or a chronic endometritis. So in 91% found an infection with the chronic endometritis or mycoplasma. 13 of these patients, so 54%, achieved after management a pregnancy. 11 had a single baby born, and 2 of these women had twins. This is the details of the management of these 13 patients. So 2 of these patients were treated for mycoplasma. 1 was treated for mycoplasma and anaerobic bacteria. 1 was treated for anaerobic bacteria, and after treatment, we made hysteroscopy with biopsy to be sure that there is no chronic endometritis. For the patient, 4 patients had chronic endometritis treatment after chronic endometritis were detected with hysteroscopy. Donc there is no bacteria detected, but in hysteroscopy with biopsy, there was chronic endometritis diagnosed. 1 patient diagnosed and treated for chronic endometritis, and the man stopped smoking. 1 patient, chronic endometritis treatment, plus endometrial polyprosection. 1 chronic endometritis treatment, endometrial scratching, and psychological support with hypnosis. For this patient, we used hypnosis because the patient was very, very stressed. It's a patient who had 7 implantation failure before coming to our center. 1 patient had chronic endometritis treatment plus thrombophilia diagnosis and treatment with low molecular weight heparin. And for 1 patient, we just suggested to the male to stop smoking. The male is a heavy smoker. So as you see, the infectious cause was very present in the cases of repeated implantation failure we encountered these 2 last years. And Ciccinelli, in his paper entitled Prevalence of Chronic Endometritis in Repeated and Explained Implantation Failure and the IVF Success Rate After Antibiotic Therapy, found nearly the same results as 66% of women with repeated implantation failure were diagnosed with chronic endometritis at hysteroscopy. Common bacteria and mycoplasma were the most prevalent agents. At IVF attempt after treatment, a significantly higher pregnancy rate and live birth rate was reported in the group diagnosed and treated. So my take-home message will be most of implantations failure are due to aneuploidy first. 99% of implantation failure are due to aneuploidy. So the true repeated implantation failure, so which have another cause than aneuploidy, is very rare. So it's very important to check for the usual causes of implantation failure before starting the first IVF, with a special care and attention for microbiological investigation. We don't have to make a hasty diagnosis of repeated implantation failure to avoid inappropriate actions. And in case of implantation failure of many euploid embryos, we can propose a hysteroscopy, if not already done, to check for and treat a possible chronic endometriosis, and search for thrombophilia and treat with low molecular weight heparins. Other interventions exist, but more evidence is required to precise the place of each of them. And I thank you very much for your attention.